Welcome back to the Canadian Concussion Center's webinar series, which is sponsored by the Labor's International Union of North America, LIUNA. My name is Leslie Rattan, and I'm really pleased to be moderating our webinar series, which was developed for individuals that have suffered a concussion, their caregivers, as well as healthcare providers. And sessions, if you've been with us before, you'll know that they focus on various symptoms, aspects of concussion, and we start with an expert speaker, and then there's an opportunity for you to submit your questions and get those answered in the second half. And just so that you know, the sessions are recurring every other Tuesday evening from 6 to 7 p.m. I'd like to just begin by acknowledging the Indigenous peoples of all the lands that we are on today. Well, while we are meeting virtually, I'd like to take a moment to acknowledge the importance of the lands which we each call home, to reaffirm our commitment and responsibility in improving relationships between nations, and to improving our understanding of local Indigenous peoples and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. So back to our webinar series, if you haven't been with us before, just to let you know, all of our webinars are recorded and you can find those on the Canadian Concussion Center's website. And Josh has very kindly just put the link into the chat. So if you want to look for any of our previous ones, you can find them there. If you do have a question tonight, if you just look to the bottom of your screen, you'll see that there's a Q&A. Please enter any questions there. There's also a chat button. If you're having any technical difficulties, please enter those there and Josh can help you out. We also are just going to run a short poll that we always do just to get a sense of who is in our audience this evening. So I'm going to just give you a second to click on that. Perfect. And now we're just going to jump into the session. So for this evening's session, I'm really pleased to introduce, welcome back actually, Dr. Marie Slegr, who is going to be presenting on headache types and treatment. Dr. Slegr graduated from the University of Ottawa Medical School in 1984. She completed internal medicine training at the University of Ottawa, followed by a neurology residency at McGill University in 1991. She's been a practicing community neurologist in Toronto since 1991. She was an active staff member in the Department of Medicine at Centenary Health Centre in Scarborough for 12 years, and now has an adult general neurology practice with an interest in headache in Midtown Toronto. So with that, I'm going to turn it over to Dr. Slegr.
Okay, well, thank you very much, Leslie, for that very kind introduction. And I do appreciate being asked to speak to this group again. I've done it a few times before. Anyway, so there's my title slide. Here we go. Now, I think we have to start by some definitions. And So I bring you to something called the International Classification of Headache Disorders, 3rd edition, ICHD3. And that's important because we really want to know what we're talking about. We have to be speaking about the same things so that we can move forward to provide appropriate treatment to patients. So in the the ICHD-3, they do have headache attributed to trauma or injury to the head and or neck. So this would be the type of headaches that we're discussing this evening in the context of concussion. This may present as a simple isolated headache, but more commonly it's an association with a bunch of other symptoms, which I've listed here, such as dizziness, fatigue, mental symptoms like reduced mental concentration, mild memory loss, psychomotor slowing, which really is sort of depressive symptoms, insomnia, anxiety, personality changes, irritability. And when you have headache in association with some of these symptoms, then we sort of define it as the post-concussion syndrome. And in fact, if you look at the ICHD definition of headache, they say that the symptoms of the headache resemble primary headache disorders. So let me describe what I mean by primary headache and secondary headache. Secondary headache is when you have a headache due to something. For instance, headache secondary due to a brain tumor or due to a stroke. So it's a headache arising from an other condition. And then we have secondary headache, which would be these post-traumatic or post-concussion headaches, are secondary to the head injury, but they have features resembling primary headache disorders. And so I've listed here what are the typical primary headache disorders that we would say, are the types of headache that we find out about when we question patients. So there's tension type headache, there's migraine type headache with and without aura. Also, there's a type of headache in the ICHD classification that talks about persistent headache attributed to whiplash. And a lot of the patients that are referred to a concussion clinic or seen in this context actually do have a whiplash type injury, often in a motor vehicle accident where there's a acceleration, deceleration type of injury. For instance, with a rear end collision, head goes forward, head goes back, the neck is implicated, and headache arises from that. And then, of course, I actually include here medication overuse headache, and we'll discuss that a little bit further on in the talk. But I think it's important because many of the patients who we do see end up with extremely frequent, if not daily, headaches, and there's a very real risk of medication overuse occurring, which is a complication added to the underlying headache. So let's look at the definition of migraine without aura. So typically these headaches should last at least 4 hours or longer. They say up to 72 hours. That's without treatment or with treatment that is ineffective. And then at least 2 of the 4 following: unilateral location, that means one side of the head, it could be right or left; pulsatile, which means throbbing type of pain, moderate to severe in intensity, worsened by simple activity or avoidance of simple activity because it worsens the headache. For example, just simple walking or climbing stairs, bending over. And then at least one of the following: nausea and vomiting, light and or noise sensitivity. So these are migraine features. And in my experience, most of the headache or concussion headache patients are going to talk about a lot of these symptoms. And, surprisingly, some of them come in: I have all the symptoms of concussion. I've got the light sensitivity. I've got the nausea. I've got the pounding headache. Well, if I didn't know you hit your head, I would say it sounds like a migraine. And then it's a pretty low threshold in terms of saying this person has migraine because you just need 5 attacks in your life fulfilling those criteria. And there's no other alternative diagnosis that can account for that headache. Now, a word about aura. Aura is a neurological phenomenon associated with migraine, but most migraine patients don't experience aura. Maybe up to 30% of migraine sufferers would experience aura. Aura is a temporary neurological phenomena. It's often visual. So patients will say, I started seeing some flashing lights or some zigzag lines in my peripheral vision, and it kind of moved around, and it started small, and then it gradually increased, and then it sort of disappeared. It went on for 20 to 30 minutes, and then the headache came on. And so that's a typical description of a migraine with aura. Most people don't get aura. I've certainly in my practice seen patients who were referred for post-concussion headaches. They've got migraine features, and then for the first time in their life, they started getting a classic migraine visual aura. And so that tells me that their brain was sort of wired to get, migraine because, there's nothing else that causes aura. We've most of the time patients have had some sort of neuroimaging, meaning a CAT scan or an MRI. And, in concussion, we won't see anything. It's going to look normal. So if a patient is experiencing migraine visual aura and the scan doesn't show any other alternative explanation, that brain is predisposed to make migraine. Okay, next, tension type headache. It's somewhat different. It's bilateral. That means both sides of the head. non-throbbing, and it's mild to moderate severity and no other associated features. I have to say, most of the patients that are referred for post-concussion headache to me are the patients who didn't get better quickly after their head injury. And they typically don't come to see me saying, oh, well, I've got this sort of, not very severe, mild headache. I don't have any light sensitivity. I'm not nauseous. So I'd say that this is probably in the minority in my experience. Then I mentioned this persistent headache attributed to whiplash, which is one of the ICHD, definitions. So it's a headache fulfilling criteria C and D. Under B, they have, well, the patient has sustained some sort of whiplash injury, which is associated at the time that the neck pain and headache has commenced. And then it should have developed at least within 7 days after the whiplash, persists more than 3 months after it began, and not better accounted for by any other ICHD3 diagnosis. One of the things, that a lot of patients will have, even if they didn't really have whiplash, but they had some kind of concussion, a lot of patients still have neck pain. And a lot of people will say, well, the neck pain is causing my headache. But in fact, neck pain is a feature of migraine. That is not something that is captured in this ICHD classification. They don't talk about neck pain, but in practice, we know that neck pain is a really common symptom with migraine. And therefore, in the concussion patients, even without whiplash, they may have a lot of neck pain. And I think that speaks to the way this pain circuit is wired. You get referred pain into the neck, and we do try to treat that. Not necessarily with specific treatment to the neck, but rather we look at that neck pain as part of the whole headache syndrome. Now, medication overuse headache, I said I wanted to mention this, and it's when you have more than 14 headache days a month for 3 months using analgesics too frequently. How much is too frequently? Well, simple analgesics, which means simple things like acetaminophen, ibuprofen, using them more than 14 days a month for 3 months, you're in medication overuse territory. If it's prescription analgesics, there's a lower threshold, more than 9 days a month. What does that mean? The medication may be contributing to making your headaches worse. So we want to avoid that. That's number one. It might be making your headaches worse. And secondly, using these medications excessively may be bad for the rest of your body. For instance, ibuprofen, which is a non-steroidal anti-inflammatory, may cause gastric irritation, ulcers, ruin your stomach. It may be, detrimental to your liver and your kidneys. So there's a lot of reasons we really want to back off on overuse of analgesics. Now, treatment. So I've discussed that concussion headache isn't a special kind of headache. It actually has primary headache type features, and that will guide our treatment, because if it's got migraine features, then we will use migraine type approach. And I said most patients have migraine features. So acute pain relief. That means painkillers. What do we use in the moment? We do want to offer people pain relief in the moment. Like, I'm really having a bad day. I want to try to, get rid of this headache or lessen it today. So non-prescription simple analgesics, which most patients are familiar with, acetaminophen, and non-steroidal anti-inflammatory drugs. That's things like ibuprofen and naproxen. Then we do, if those are ineffective, and they often are, we go to prescription analgesics. We use triptans in migraine, and I will use them in this patient population as well, that are the post-concussion patients. Also, we may use prescription strength non-steroidal anti-inflammatories, including naproxen, which will be a higher dose than we use in the over-the-counter naproxen, diclofenac, which is available in a formulation that comes in a powder that's dissolved in water and has a very rapid onset of action, and for some patients is extremely effective. And I don't want to be promoting brand names, but there's only one product that comes in that powder formulation that you have a sachet and you blend it in water. It's called Cambia, and that is a non-steroidal anti-inflammatory only for migraine, and we use it in this context as well. But what's really nice about it is its rapid onset of action in terms of an oral medication. It's probably the fastest acting oral medicine in this sort of group of medications. Triptans may take up to 2 hours to work. So when patients need fast relief, this can be quite a good drug. Then what we do have that's new, and since I last gave this presentation, I guess, are GPANs. GPANs are migraine-specific acute treatments. Well, at least one of them is, because they cover both acute treatment and also preventive, which I will get to. So we have ubrogepant, which is available now in Canada for about a year. And what's nice about these drugs, they can be given to patients who triptans don't work or triptans are not tolerated. So some patients will say the triptan works, but it makes me extremely drowsy and I can't function. Or I have heart disease and I'm not permitted to take triptans. So GPANs are thought to be safe in that context. We do want to avoid combination analgesics. So what are those? The so-called Tylenol number one, what's that? Acetaminophen with caffeine and a weak opioid called codeine, or Percocet, which is oxycodone and acetaminophen. We really want to avoid opioids. We really discourage the use of opioids. There's so many risks with it. Not only, well, everybody's very aware of the opioid crisis right now with addiction potential and abuse and misuse, etc. But not only that, they may actually make the headaches worse. We don't want to do that. So we stay away from those as much as possible. Medication overuse, I've sort of covered that. Simple analgesics, no more than 14 days a month. Prescription, no more than 9 days a month. Preventive treatment. This is really sort of a very important part of migraine, or I should say chronic headache, post-concussion headache treatment. And what are the goals? The goals are to reduce the frequency, severity, and duration of attacks and the associated disability. And I think we've often not talked about disability. We always talk about headache diaries and how many headache days a month you're getting and how many headache-free days. That's one way to frame the discussion and following, whether we're getting benefit with our interventions. But disability, and what's disability? How many days a week or a month am I missing work or missing school or unable to function? I can't take care of my children, or have to call in sick to work or leave work early, or, missing class if you're in university, that type of thing. Or even, other things. My social life is limited by how much headache I'm getting. Or I'm not able to hold down a job. So all of these are really important sort of things that we monitor and try to improve. Treatment isn't all about doctor, give me drugs and, let's try to cure this. Lifestyle is very important. So I try to engage my patients in, actively managing themselves, which includes attention to sleep, keep regular sleep routines, try to get, 7 to 8 hours a night if possible. A lot of patients do have sleep disturbances and insomnia, but we do talk about sleep hygiene, which includes, sleep routines, regular bedtimes and wake up routines. Try not to be irregular. Your brain has a little clock in it. If you keep changing the time, it doesn't know when it's supposed to do things. So you want to keep nice, regular routines. Second thing is avoid drinking too much caffeine, which may disrupt sleep. Don't have any caffeine afternoon. I usually say limit it to 2 cups a day or less of all caffeinated beverages, which includes coffee, black tea. Green tea has some caffeine. And of course, remember things like Red Bull and these caffeine beverages, pop, certain kinds of pop, Coca-Cola type has caffeine. So you want to look at all those things. You also want to be careful about winding down at night to get your body ready for sleep. Screen time, limit that towards bedtime. For 2 or 3 hours, the bright light wakes up your brain, turns off your natural melatonin, which you make when it's sort of exposed to darkness and is to initiate the sleep cycle. But if you turn it off by, exposing yourself to bright screens and light, it may disrupt your sleep. Nutrition and eating habits. Regular, 3 regular meals, including breakfast, within 1 hour of getting up in the morning with some protein. I talk about 12 to 15 grams of protein. How would you do that? Well, 1 egg is 6 grams of protein. 2 eggs, it's just 2 eggs. That's it. Now, I'm not saying you only eat protein, but protein is the backbone of the meal, and it gives you nutrition that's going to give you staying power to your next meal, which is midday. You don't want to skip meals. You want to give enough energy, food energy, to your brain so it's not running on empty, which increases the risk of headaches. Fluid intake, very important. You want to have enough fluid so you're not dehydrated and getting headache on account of that. And plain water is a good kind of fluid. You don't have to have electrolyte and all this kind of stuff. It's just plain water is good. Exercise, very important. Physical exercise, particularly aerobic exercise. What does that mean? Exercise that gets your heart pumping and your heart rate up. Now, some patients with concussion, many patients will say, when I do that, my head starts pounding. So you want to exercise to below threshold of triggering that and gradually increase. And I mean, it may be very slow at the beginning. It can be as simple as walking. It doesn't have to be a gym. Some patients like an exercise bicycle because it's more convenient, maybe if the weather's bad, and they also can sort of modulate their activity a bit better. The benefits, though, of going outside with the natural light, fresh air, and even seeing nature, and it can't be understated. So anyway, that's what I recommend. I don't think you have to get a trainer and anything fancy. It can be as simple as that, but it's important to get it every day. Stress management. Okay, all the things I've talked about above help with stress management. If you're tired, hungry, thirsty, out of shape, physically out of shape, you don't manage stress as well. So that's part of stress management. Then the next is, can you incorporate things like meditation, mindfulness, which is available even without, finding a professional to help you. I mean, there are mindfulness apps. I mean, even on Spotify, I've seen mindfulness, 10-minute sort of tape, and it's for insomnia, for feeling anxious. And, why not try it? It might be helpful. And then some patients, of course, might need some professional help with therapists and that, although not always accessible because of, costs, etc. Non-prescription preventive. So this is in the migraine realm, but we will, recommend it to patients with post-concussion. Riboflavin, which is vitamin B2, 400 milligrams per day. Couple of comments. It can be hard to find. It may not be on the shelf in your supplement aisle of your chain pharmacy. You could ask the pharmacist. They may have it behind the counter. They may order it in for you. Some patients have, sourced it at, sort of health food and vitamin stores. Some people have even found it at, something like Costco, and I'm not trying to promote Costco as such, but it's sometimes difficult to find. Magnesium. Magnesium is easy to find. What kind of magnesium? The same chain pharmacy, you go to the supplement aisle, you'll see 12 types of magnesium. It's always magnesium something. It's a magnesium compound. You can't take pure magnesium because it's a metal. So you want to get like a tablet or a powder or something. So we often will say magnesium citrate or magnesium glycinate. Are available, and you're aiming for around 400 milligram, about the same dose as riboflavin. I mean, sometimes they're in capsules of 150, so you do roughly, 3 capsules, 450. Take it at bedtime. Magnesium can help sleep and help people feel relaxed as well. Now, if you get loose bowel movements on that dose of magnesium, you have to reduce it. Okay, so you're aiming for your bowel habit to be normal, not excessive and loose, and so that has to be adjusted if downwards if you're getting that type of effect. And then there's this coenzyme Q10, 200 milligrams a day, and that you pretty well always find in the supplement aisle of your chain pharmacy and other sources. And the trick here is you have to take it every day. You have to take it long enough. So here are principles of preventive treatment. You start low and slow and gradually increase. Now, when I say this, I'm talking about the prescription drugs. The supplements, you probably can just start off right away. But and then you need to take an adequate dose, which will depend on the specific prescription drug, adequate duration. So taking it 2 weeks and I'm not better, doctor, well, it's not going to take 2 weeks. It's going to take a few months. And so I usually encourage people, please stick with it for 2 to 3 months, unless you're not able to because of side effects. And then we individualize the prescription drugs to patients' comorbidities. And I'll talk a little bit about that in a bit. Right now, comorbidities, insomnia. So we may choose a drug that has some sedative properties as a side effect to help patients who have serious insomnia. BMI, that's body mass index. That means we're looking at, is someone overweight? We look at certain drugs and some of them promote weight gain. So maybe we want to stick with the drugs that don't promote weight gain. And I'll get to that when we talk about the specific medications. We look at other comorbidities, very important, depression and anxiety. These are really common in our concussion patients and also in our general primary headache patients. It's very common. So there may be medications that work better for those patients that might do dual purpose. And then we have to think about other sort of conditions that we might avoid certain drugs because, for instance, they have asthma. First-line drugs. First-line drugs, tricyclic antidepressants. Examples are amitriptyline, nortriptyline. These are really old drugs. They're taken usually once a day. Side effects, however, are things like sedation, dry mouth, weight gain. Beta blockers, propranolol, nadolol. These are drugs that keep the heart rate and blood pressure from rising with stimulation. So patients may have exercise intolerance. This is the drug we can't give in asthma. Anti-seizure medications, topiramate, gabapentin. Topiramate is one of the drugs that doesn't cause weight gain. So that's a nice feature of it. However, potential side effects include cognitive side effects, word finding difficulty, feeling not as mentally sharp, and tingling of the extremities. Gabapentin is sedating. Some patients will find it quite useful to do that dual purpose if they have severe insomnia, but weight gain is another potential side effect. Then an antihypertensive, candesartan. It's actually one of my favorites, really, because the side effect profile is so good. It doesn't cause weight gain. It doesn't cause sedation. And the main thing is, well, could it lower your blood pressure? It could, but we seem to get away with it a lot. And we sometimes get away with kind of modest doses and it works. So it's one of my favorite ones, especially as a first line. And then the SSRIs, which is selective serotonin reuptake inhibitors, which are for depression and anxiety, but we use them also in headache management. And for some patients, this might be a good dual purpose drug. Second line, onabotulinum toxin A, also more commonly known as Botox. So this would be if a patient fails a few of the first line drugs, and most drug plans will say, what have you tried and what have you failed? And so you usually have to hit that threshold of having tried and failed at least 2 of the first line drugs. And it's really indicated for chronic migraine, which is defined as headache 15 or more days per month for 3 months. Most of the concussion patients will satisfy this criteria, but we have to look for those migraine features because, otherwise it's not really indicated for post-concussion headache. If I can make a case that the patient seems to have migraine features and they probably had pre-existing migraine in the past, and I often ask about that. And I get that history that, oh yeah, I used to get, I remember being in grade 8 and I had pounding headaches and throwing up and stuff. Okay, you've had migraine before all this concussion happened. So I can make a case for saying, I think Botox would be a potential treatment. And then we have newer medication, CGRP monoclonal antibodies. You might say, what is CGRP? It's calcitonin gene-related peptide, which is an important player in producing migraine. And these block that and are quite effective and well tolerated. And then GPANs is the latest thing. I did mention another GPAN, which was for acute treatment. We also have a preventive, but it's only for episodic. So it really doesn't, probably for the majority of the patients we see, is not appropriate. Okay. Conclusion, post-concussion headache is really challenging to treat. The approach includes a careful history to identify the headache features, comorbidities, and risk factors. A holistic approach is needed. That's lifestyle as well as medications, but more research is needed. We actually don't have a lot of evidence, scientific research that says how is the best way to treat this? And then some take-home points. Do maintain a healthy lifestyle. There are things you can do. You have agency in this. Consider a preventive medication. A lot of patients are reluctant. I don't want to go on a daily medicine. Practice stress management. Please exercise. And then don't forget comorbidities. Don't forget the other things that are going on apart from just the headache part. And be careful about overuse of analgesics. And with that, I thank you very much for your attention.
Great. Thanks so much, Dr. Slegr. That was excellent. Okay, so I'm just going to shift over to, we've got a number of questions. Our first one is, I've been told some conflicting things. A neurologist that referred me to the otologist, current physio, and another have said to avoid activities with risk of falling or bumping their head, and to gradually increase the time in triggering environments for desensitization if symptoms are still being experienced. And then they're saying they had another neurologist through WSIB that said that they can do everything with no concerns. And they're wondering if you have any comment on which might be the more appropriate recommendation.
Well, I mean, you want to avoid activities that are at high risk of another blow to your head. So, for instance, okay, I want to play my pickup hockey game once a week that I usually do. Probably not. If you're still symptomatic, I think you should be totally better before you start doing things like that. I mean, some patients, they got the concussion playing hockey, but, I'm just wondering, because it's a WSIB question, then, probably was a workplace related injury. But, you'd want to avoid things where, yeah, I might hit my head again. Hockey, yeah, that's an example, or skiing, or, so you probably want to avoid that kind of thing. But we do want patients to try to also remobilize, because, a number of years ago, people were saying, well, you're on bed rest, cognitive rest, you go in your bedroom, you close the blinds, and you're not allowed to do anything. And those patients didn't do as well, and wait till you're better. And some of them never got better, and they did worse than the patients that we said, okay, you can have a little bit of a, rest, maybe a couple of days or something, some days, but not weeks. And we need to remobilize you. And there's some studies in the pediatric literature that showed the kids that were remobilized early did way better than the ones that were put on this very prolonged rest. And part of it is patients develop depression and they become deconditioned. Deconditioned means out of shape. And so they start trying to walk and they're out of breath and they're tired and their head is killing them. But they've been lying in bed for 3 weeks. So we need to get people back, and it can be very gentle, and you sort of build up gradually. But lying around, not good. After a few days, lying around, not good. So you've got to get remobilized and trying to get back doing some things, and then you do it to a level that you can tolerate, and you try to increase very gently. Yeah, that's my.
Great. Okay. Thank you. Um, Another one with a WSIB portion to it. Finally had an appointment with the WSIB specialty clinic. I'm about 10 months post-concussion, still having some symptoms, mostly dizziness and fogginess, feeling almost drunk, but in a bad way, and fatigue triggered by sounds, head movements, and visual clutter, which have been decreasing in severity and duration, most notably after starting osteopathy in February. Which sounds like they're also using along with massage and some physio. I just had an appointment with a neuro-otologist today where some actual testing was finally done and showed an inner ear issue is causing some symptoms. I have an upcoming orientation appointment for multidisciplinary treatment at a clinic where they're going to have physiotherapy, a kinesiologist, and an occupational therapist. The neurologist from the WSIB clinic has also prescribed venlafaxine for brain fatigue and energy levels starting at 37.5, increasing to 112.5 after 4 weeks. And they're wanting to know is thoughts on whether this is reasonable and what they should be doing, and also any questions that they should maybe be bringing to that appointment.
Oh, that's a really dense
It's
one,
a
but
lot one,
I
sorry.
mean, it's okay, but that's a really a typical scenario as well. I'm just thinking there's also headache in there, I guess, but I mean, most of the patients I see, there'll be headache thrown into this and they feel dizzy and pain and the whole bit. But anyway, so if there is an inner ear thing, which is quite inner ear condition, which is quite common, um, that that actually has specific things to address it. And I mean, I was actually looking at Dr. Rutka's presentation from a few weeks back, and he does talk about this. And there are some physical um, therapy maneuvers for those patients if they determine that there's an inner ear thing that would lend itself to improvement with that. And there's special vestibular physiotherapy, and vestibular implies this inner ear business. And then the venlafaxine, I think that's a great idea. And they started at a really nice low dose, which is typical. Like I said, you start low, slow, and gradually increase, and you may need to get up to it depends. I mean, 75 milligram is not a crazy high dose, but some patients will even get up to 150 or something like that. So, but it is a slow process in terms of the titration of the drug, and then slow to see the full benefit of it either. I mean, we're talking about a brain, the brain. It's not like a switch on off. It takes some modulation, and you've been like this a while, so it takes a while for things to kick in and you know do their work.
Great. Okay. Thank you. Next question is from Dr. Rizos. How does one distinguish and manage migraine triggered by head trauma versus migraine-like headache caused by head injury and concussion? Provided there's no overlap, return to sport or activity management may be different.
I don't think there's a difference. I think your treatment is dictated by the frequency, severity of the headaches, and then how long it's been going on for. So, I mean, if you're seeing the patient a week after the head injury, you're not necessarily going to put a person on preventive, because number one, preventive takes a while to work. And some patients, improve spontaneously. So over a few months, they'd be better. And, if you started a preventive right away, you're not really, you might pat yourself on the back and say, oh, I'm so good. My medicine really worked, but it was the patient spontaneously improving. You want to see if this is going to be a persisting problem. So, and I almost never see patients that early in the process. I see them months and months after, like more this 10-month or sometimes even longer. And nothing has really, they haven't gotten better spontaneously, and they may have tried some things before they get to me. And so, yeah, we've got to do something because this is a persisting chronic problem. But I don't see a difference between, I mean, I guess you're suggesting concussion, which is considered mild traumatic brain injury, versus something more severe. I don't really see the difference. to tell you the truth, because, we're treating the symptom. And honestly, there isn't really anything like, there's not really special treatment specifically for, we treat the symptom, not that, oh, well, it was this kind of head injury. I mean, unless there's something surgical in there, like there's a subdural or something, and then that's not really what we do. We would send them to the neurosurgeon to fix that. They sometimes send them back to us because they said the headaches didn't go away after we did,
Hmm.
our procedure. So
Right. Okay, thank you. And I'm just gonna, just for those of you that are submitting questions, if you can put them into the Q&A as opposed to the chat, I will try and switch over to the chat in a bit, but I can see that people are putting things into the chat as well. But if you do have a question, just put it in the Q&A. So we had someone asking about, they're wanting clarification about when you were talking about neck pain. And they're saying, just to clarify, did you say that neck pain can also be the result of, um, not per se always the cause of or contributing to the headache?
yeah, it can be actually a symptom of the headache rather than, because a lot of patients will say, I get neck pain and then I get the headache. And they say, there, ergo, my neck is causing my headache. But in fact, so in migraine, neck pain is a feature. And with the pain circuit that causes the headache, we have, the pain circuit going into the upper cervical spine, which is the upper neck spine. And it's actually part of the whole pain circuit. So the reason I bring this up is because people will say, I've got all this neck pain and my headaches are out of control and my neck is causing my headaches, but I've done all the treatments. I've done the physio and I've gotten, nerve blocks in my neck and it's not helping. What's going on? Well, reverse the, causation and it starts making sense. If we say it's originating in this pain, the central pain circuit that's in the brain, and that's giving you outflow to your neck. That's, then it makes more sense. And, Botox, we do injections in the neck and shoulders and back of the head, a lot of injections, actually, about 50% of the protocol. And it actually covers that area. So it's actually a good treatment for patients who get a lot of neck pain in association with this. And it's sometimes very helpful. So that's just my kind of, explanation for this. And a lot of patients are very, just troubled by the fact that, well, all these neck treatments didn't work, and
Mhm.
so that would be my counter to that, that kind of thinking about it.
Great. Yeah, thank you. Next question. If the non-prescription treatments didn't work and you graduated to gabapentin, is it still helpful to take the non-prescription treatments? So I'm assuming things like the magnesium and
Yeah. Um, I often, well, I tell patients, what do you want to do? Because some patients are very motivated to stay on those, and I think it's okay. It's a lot of pills, though. So if you're on B2, magnesium, I mean, we're talking about 4 plus, maybe 3 plus 1. I mean, it's about 8 pills. It's a lot of, pills to swallow. So some patients, it's too much for them. And so I say, listen, it's okay. If they didn't really do very much, put them aside, stick with the gabapentin. But some patients want to stick with those. They feel they like to have the natural, side of it. And
Mhm.
I mean, there's no study, I don't think, that has looked at synergy between the sort of non-prescription nutraceuticals, but there might be. And so some patients like to have that, together. So it's kind of an individualized thing. And, for some patients, it's way too many pills to take as well as, getting onto a prescription drug.
Mhm. Okay. And sort of on that same note, we've got someone saying they've been struggling with persistent symptoms for years following a concussion. They consulted a neurologist who diagnosed them with migraine and prescribed magnesium glycinate
Yeah.
and vitamin B2. They say, I tried 100 milligrams of magnesium, but it made me groggy all the next day. No problem with the B2. And they're wondering, is there a substitute for the magnesium? They said
Not
they tried a
really.
quarter tab and it was still too much, which,
Yeah, wow, you're very sensitive. Um, Not really. I mean, that's a low
yeah.
dose. And I mean, the only thing I can say is, I mean, are you taking it very late at night? And, would it help to take it earlier, something like at supper instead of like at, 11 p.m. or something? That's the only thing I can think of. Otherwise, maybe it's not for you. And I mean, of course, everything is always very individualized. So if a patient tells me, I have patients who tell me they don't like B2, they say they don't, it upsets their stomach, they feel unwell on it. Okay, cut the B2 or take less. We individualize it to patients according to tolerability. The nutraceuticals are usually well tolerated. Prescription drugs, we have a lot more problems with tolerability, especially those first line drugs that I sort of mentioned. But right now, that's where we're at. Those are the guidelines. Well, there's an updated there is an update to these guidelines of the drugs, but it's not available yet. So I really didn't talk about that. And I
Mm,
actually don't know all the new guidelines, but I've heard, oh, we've been working on them and they're going to come out soon. So anyway, stay
mm.
tuned on that one.
Yeah, yeah. Okay, thank you. Next question. What about medical cannabis? After trying all the other medications and side effects that outweighed the benefits, CBD with just less than 1% of THC works really well. After years of hesitation due to the stigma around it, they've been working with a cannabis doctor at the Canadian Cannabis Clinics, providing guidance for products and dosage, uh, and seems to be helping them out now. Any thoughts on that?
Yeah, well, it's really not part of what I recommend usually. And why is that? There's not much evidence. We do not have really there's very few studies with cannabis. Um, and, although it's widely used and we have these cannabis clinics, and especially in Canada, it's really picked up in its use because it's legalized. But, this legalization is interesting because why are there no studies? Well, it was illegal, and especially in the U.S. with the war on drugs. I mean, there was no way people would be able to conduct research on cannabis, and there may be some benefits, but unfortunately, there's no guidance from the scientific literature to say, okay, we tried this, type of compound, what percentage, and it's complicated because you can get like, how much percentage of CBD, and it's a very complex molecule, what you're having. So I actually don't use it, and I mean, I know there's patients out there that find it's beneficial, but I can't really recommend it because of the lack of the evidence. There's also downsides of CBD. I mean, side effects. What does it do in the long term for cognition? We just don't know. So I hesitate to say, yeah, go ahead. I would recommend. I don't recommend it. It's not part of my practice. And anyway, so that's my view on that.
Okay, thank you. Next question. After more than a year, it still hurts when I touch the top of my head, resulting in a headache. And they're wondering, why is this?
Oh, that's called allodynia. What does that mean? An innocuous stimulus is painful. Just touching your scalp, that shouldn't hurt. Combing my hair, wearing my glasses, it hurts, doctor. Patients will tell doctors sometimes that, and the patients get the impression the doctor thinks they're crazy. But this is called allodynia. So what is that? That means your pain circuit has been sensitized. It's overly sensitive. So it is interpreting simple, innocuous, not dangerous stimuli as painful. And so we see this in chronic headache. And chronic migraine, the patients have allodynia. So what we're trying to do is turn down the sensitivity of your pain circuit. And this is where all those things that I talked about as treatment, particularly the preventive, is to turn down that hypersensitivity of your, pain circuit. And that's how you treat that. because usually it's associated with a lot of headache.
Mhm, mhm. Okay. Next question. I'm 5.5 years out from the concussion. I've tried a number of drugs without benefit. I'm on gabapentin now, and it's helped a bit, but still have daily headaches, especially with screens and long drives. And they're
Mm-hmm.
wondering, when do you know when it's time to try something different?
Okay. So what do I usually do? I mean, all of these, every drug has sort of a dose range, and gabapentin happens to have a dose range. I mean, what's a small dose of gabapentin? 300 milligram. What's the maximum dose? Actually, if you look at the product monograph, they say 3,600 milligram, and that's when they were writing the monograph for epilepsy. But actually, we have a sort of a threshold at 2,400 that you can't absorb anymore. So I say, okay, 2,400. It's quite a bit of medication. Um, and, it's highly variable what people's tolerance is. So some people wouldn't be able to get up to 2,400 a day in divided doses, by the way. It's never given in one shot. So usually in three times a day. Um, but so, what we do is we push the dose a bit. And then, some patients will say, I can't tolerate this. Okay, so we dial it down, and then you take it, at an adequate dose and long enough. And so long enough is 3 months. So, if somebody's been on it for that kind of time at a target dose and they can't go up higher on the dose, that's then, well, I only had, a slight improvement in my headache. Then it's not good enough. And one of the benchmarks of improvement is, have you reduced your headache frequency and severity by 50% or better, and your disability? So some patients, for instance, they say to me, and this happens with the Botox and maybe the CGRPs. Um, well, I'm still having a daily headache, doctor, but you know what? I can do stuff again. I'm back at work. I can work. I can tolerate the screens. I can, spend a couple of hours on my computer again. Um, I have more energy to do a full day again. So that's sort of how we judge it.
Mhm. Okay, great. Uh, I've been dealing with pressure in my head on and off for about 6 years post-concussion, and 95% of the time, the pressure only emerges when I engage in physical activity. Some days I'll go for a short walk and feel okay, and the next day, after doing the same things, so everything's remaining the same, they're eating the same, they're sleeping the same,
Right.
I get the pressure symptom in my head. Do you have any ideas what causes the unpredictability in terms of this symptom onset?
Oh boy, that's a tough one.
Yeah.
That's the mystery of the brain and nervous system, and I don't know. Um, I mean, in women, blame the hormones sometimes. So sometimes that can be a component, and in men, we can't blame hormones, at least not usually. Um, but that's the crazy unpredictability of this. So I don't know what to say. It's just that
Hmm.
these things are very dynamic, and sometimes you're more susceptible than others. There's certain things that may increase your risk, like hormonal changes in a woman, for instance, may increase that variability. Um, but sometimes there's no reason actually. So at least nothing that we can measure or identify, with our
Hmm.
current, understanding of things.
Hmm. Okay. Um, okay. My son, a college student majoring in music, was injured by a falling concrete brick
Ooh.
and has since suffered from extreme migraines, vestibular, and cochlear issues. Although he was an athlete, he's striving to continue a pre-concussive exercise and diet regimen. Sunlight and monitors, along with low sounds, exacerbate his migraines and, I guess, difficulties with balance. He's been on several medications, including Botox, but they haven't seemed to help with the migraines.
Mhm.
Sometimes their intensity is decreased. but it's as though he grows intolerant to them, except Botox did not work at all. Is there
Mhm.
anything specifically that can alleviate the uh, contributing factors besides not going outside, um, playing music?
Yeah. Well, see, with our treatments, we're always trying to make the brain more resilient so it can tolerate these things. I mean, sunlight is a normal thing. It's not a dangerous thing generally. I mean, we don't consider it a noxious, substance or something. So, and Botox is a good treatment, but there are patients it doesn't work. And we don't have a good way to, I don't think we have a good way to predict who's going to be a responder or not. Um, so um, you sort of have to try something else. CGRP drugs may be an option, which are newer, and that could be explored. I think in this case, but the thing is that there isn't sort of, I mean, just sort of like, well, trying to live a life with earplugs and sunglasses. It's kind of not really like that's just avoidance. It's not trying to make your brain get back to a new level of homeostasis and resiliency, right? Because normal we should be able to tolerate the lights on in an office or the sunlight or music. I mean, at a okay level. And so he's still it sounds like he's still quite ill with this. So it would be like probably an idea to try maybe one of the CGRP drugs.
Okay,
And
great.
he might respond to that even though Botox didn't work because it's a different kind of angle to it. Like, there are different
Mhm.
ways to approach these things. The drugs are different.
Okay, excellent. How important, they're asking about early intervention. How important is early intervention within 1 to 3 weeks for better outcomes? Is there anything looking at that for headache?
Early intervention, I'm not quite sure what that means.
Yeah.
I don't know what that means. I mean, um, some people might say, well, I should go to the chiropractor or something right away. I don't
Hmm.
think we really have any evidence that that would prevent a patient from becoming one of these patients that has persisting symptoms beyond the, whatever, a few weeks. Um, I would say if somebody, yeah, I don't really have an answer to that, but I'm not quite sure what you mean by early intervention either.
Yeah. Yeah. Okay. Thank you. Uh, Next question. After nearly 7 months with symptoms, I was able to get into a clinic, receive Botox for frequent migraine and headache, and after a couple weeks, worked very well. The first Botox treatment is now wearing off, and so they're upset because the headaches are back. They're just wondering how long should the Botox be lasting in terms of
12
pain
weeks,
relief?
12 weeks. And if you respond, I mean, believe it or not, it's not a one-time treatment and I'm cured. No, 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 no. When we initiate Botox, I mean, what I tell patients is number one, it may not work with the first treatment, but you're lucky if you got benefit with one treatment, but it wears off in 12 weeks. So generally we end up having to treat repeatedly. I mean, that's the idea. We don't like when I initiate Botox, I say, listen, this is going to be a long-term treatment. I mean, if a patient is on it for a couple of years, every 12 weeks, that's like 4 treatments a year. And they start saying, you know what, I'm really feeling good. We might increase the dosing interval and try to wean them. Okay. But, one treatment and they're coming back. Yeah, that's the way it works. I mean, if a patient gets benefit with one treatment and they don't need to see me again, I mean, well, I would say that's very unusual. So typically we book people to have a treatment every 12 weeks.
Okay, Excellent. I just realized that we are now at time.
Oh,
Uh, Thank you so much, Dr. Slegr, and thank you everyone for attending. I apologize that we weren't able to get to everyone's questions, but just to remind you, Dr. Slager's presentation will be going up on the website, and her previous ones are there as well. So you can always go back and take a look. Just to remind you as well that there'll be a short survey coming your way. So if you do have a couple of minutes to fill that out, we really appreciate your feedback. It does ask you if there was any question that you didn't get answered. So if there is a question, by all means, put it in there. Just please put a contact email in there as well, because sometimes I will get questions, but I don't actually know who they're from because the surveys are anonymous. So thank you very much. And just a reminder that our next session is in 2 weeks on April 30th, and we've got Dr. Eric Massacott, who's going to be talking about whiplash and spinal injuries. So thanks so much, Dr. Slegr. That was excellent. Have a good
thank
night.
you. Thank you very much, everyone.
Take care.
Goodbye.